Hello, everybody, and welcome to our review of the lupus literature from May. We record these podcasts for you every month, so you will always be able to keep up to date on the latest literature and expert opinions. My name is Dr. Maria Dall'Era. I'm the chief of the Division of Rheumatology at the University of California, San Francisco in the United States. And it's my pleasure to welcome my friend and colleague, Dr. Vibeke Strand, who is professor in the Division of Immunology Rheumatology at Stanford University School of Medicine in Palo Alto, also in the United States.
Hello, I'm Vibeke Strand, and it's very nice to join you, Maria. This should be an interesting set of papers to discuss.
Excellent. Yes, I'm looking forward to discussing these two papers, and I can go ahead and start us off with the first one, which is a very interesting paper. First author is Dr. Prodi from the Karolinska Institute. And this paper is a post hoc analysis of the 5 phase 3 belimumab trials in extrarenal lupus. But before I delve into the details of this study, I thought it'd be helpful to review some foundational concepts so we can understand what this study is telling us. To begin with, the two outcome measures that are currently used in large-scale clinical trials in extrarenal lupus are the SRI-4 and the BICLA. The SRI-4 is anchored on the SLE, and it requires at least a 4-point reduction in the SLE without worsening by BILAG. The BICLA, however, is anchored on the BILAG, and it requires an improvement in all BILAG A's to B, C, or D, and then all BILAG B's to C or D, with no worsening via SLE or the BILAG. Importantly, the SRI-4, in order to meet that criteria, a participant in a trial must have complete resolution of at least one active organ system. However, for the BICLA requirement, a participant must have improvement in every organ system, partial improvement. The BICLA measures partial improvement. However, the SRI-4 measures complete improvement in an organ manifestation. So with that in mind, we can now discuss the data from this study. This is a post hoc analysis, as I mentioned, of the 5 phase 3 belimumab trials in extrarenal lupus. And these are the BLISS 52, the BLISS 76, the BLISS Northeast Asian, the BLISS sub-Q, and the EMBRACE trial. The EMBRACE trial was the phase 3-4 post-registrational trial of belimumab in participants of self-reported Black African ancestry. Now, in each of these trials, SRI-4 was the primary outcome measure used. What these investigators did is they went back and looked at the data from these trials on an individual trial level basis, but applied the BICLA outcome measure to these data. And they wanted to understand, how does the BICLA perform in this data set? And was belimumab superior to placebo on background standard therapy using the BICLA? So they initially compared the belimumab group and the placebo group using logistic regression models. They adjusted for trial variance. And then they looked at predictors of BICLA response in a multivariable regression model, adjusting for a variety of variables. What did this trial, or what did these studies show us? Number one, in terms of the baseline characteristics in these 2,800 participants they looked at, they're what you would expect in a lupus trial. And just to give you some examples here, the mean age was 37, predominantly female. There was good self-reported racial ethnic diversity. The mean SLE disease duration was about 6 years. And then delving into what they found, and if you look at the paper, you can see that this is figure 1A. Pulling all of the results from these trials in these participants, they found that belimumab was superior to placebo on background standard of therapy in the achievement of the BICLA at week 52. And these results were capitulated across each of the trials, except for Embrace, where there was not significance of belimumab over placebo with the BICLA. But remember that the Embrace trial was underpowered. They didn't enroll the number of participants that they hoped to enroll. And so, in fact, that trial did not meet its primary endpoint either with the SRI-4. And then they looked at subgroups of participants that might have had a better response to belimumab versus placebo when looking at the BICLA. And they looked at various measures of high disease activity at baseline. For example, SLE 2K of greater than equal to 10, or serologic positivity in terms of anti-DNA and low complement. And they found that those subgroups with measures of high disease activity at baseline were more likely to meet the endpoint of BICLA than those who did not. And that was shown. And remember that this subgroup analysis was also performed several years ago, looking at the BLISS 52 and 76 data with SRI-4. And people found those same results, that there was more of a difference between belimumab and placebo in participants coming in with measures of high disease activity at baseline. So those results were recapitulated with the BICLA. And then on the slide in front of you, you can see information here from their figure 2 in the manuscript, looking at BICLA response over time in the pooled analysis. And you can see that starting at week 8, there was superiority of belimumab over placebo in the achievement of the BICLA. And as I mentioned, the curves differentiated at week 8 at an early time point and stayed differentiated all the way through week 52. Thus, belimumab maintained its superiority all the way across the course of the trial. And then in figure 2, if you go down even further in the manuscript, you can see again better differentiation between belimumab and placebo in those subgroups with measures of high disease activity at baseline. And then what the investigators did, which I thought was also very interesting, was they looked at the effect of antimalarials. Did concomitant treatment with antimalarials improve the responsiveness to BICLA, or in terms of BICLA? And sure enough, they found that it did. Those participants that were concomitantly treated with antimalarials showed better response rates. And in fact, the group of participants with the highest response rates were those with antimalarials in addition to belimumab. And that was, of course, compared to placebo. And then lastly, they looked at overall predictors of BICLA response in the pooled analysis, adjusting for trial variance. And in their multivariable modeling, they found that treatment with belimumab was independently associated with BICLA. Interestingly, increased clinical SLE at baseline or a baseline SLIC damage index of greater than equal to 2 or low C4 were associated with a lower likelihood of BICLA response. So all in all, I thought this was a very interesting study, and it provided some important insights in terms of the efficacy of belimumab versus placebo when looking at the BICLA. And I was reassured by the fact that we found similar results with the BICLA that we saw with the SRI-4, because it's important to note that often in trials we see a discordance between SRI-4 and BICLA, but here we saw consistency of results. And we also saw the consistency of this pattern of improved responsiveness to belimumab versus placebo in those patients with measures of high disease activity. And then lastly, I think the finding, again, the reassurance that addition of antimalarial is helpful. We all know that antimalarials are the foundation of our therapy in lupus, and it was nice to see that these results also demonstrated that. So I thought this is a very interesting, helpful paper. Vibeke, what do you think?
Well, I agree. And we've learned from the anifrolumab trials where they used a SRI-4 in one trial and BICLA in the other trial, and then subsequently looked at both phase 3 trials by BICLA, that Yes, SRI4 responders and BICLA responders are reflected in those trials where there's a positive response. But on a one-to-one basis, a patient may be an SRI4 responder, but not a BICLA responder, and vice versa. So it has to be looked at on a group level. So I think that that's important. And it has a lot to do with how the SLEDI and the BILAG are scored and how differences that they have. I think the other point is that when belimumab was first being reviewed at the FDA, I was helping them defend it. And the SRI-4 was a brand new outcome measure which had been developed based on their phase 2 trial. And there was really very little understanding of these outcome measures back then in lupus. And the advisory panel was quite skeptical until we showed them the health-related quality of life data. And then that helped to convince them that, in fact, this was an effective therapy. And I think that's one of the points of this grouped analysis is that across these 5 phase 3 trials, maybe with the exception of Embrace, we really see nice efficacy data by either outcome, and particularly in those patients with high disease activity or serologic activity that also indicates high disease activity.
Absolutely. And I think before we get to the next paper, I completely agree, Vibeke. And I think for our listeners out there, it's interesting because we realize that these outcome measures of SRI4 and BICLA are imperfect, right, for various
Yes.
reasons. And Vibeke, you mentioned that as well. And that is why the lupus community has come together in the SLE TRM project, which is led by Eric Morand, and it's a multinational group to try to develop a new response measure for lupus clinical trials. So more to come on that, but that is, a response, I think, to the fact that we need better, more robust outcome measures for our trials because none of these measures that we're currently using performs perfectly well. So more to come on that for our listeners. But we'll move on to our next paper. And Vibeke, you led this next paper. You've done a lot of work over your years pioneering health-related quality of life measures, patient-reported outcome measures in lupus. This is a very important area that the field is focused on at this moment in time. So I'm really happy to be talking about this paper that you led.
Well, thank you very much. I just wanted to say that I think the CRM effort is very important, and OMERACT is looking forward to helping to validate whatever comes out of these efforts because we all agree we need better composite outcome measures in lupus, and we need to have a patient-reported outcome included in those composite measures, which so far they aren't.
Completely
So
agree. Yeah.
this is anifrolumab, and this is the long-term effect from their long-term extension, where patients from TULIP 1 and TULIP 2, their 2 phase 3 trials, were enrolled for continued treatment for as long as 4 years. So we assessed patient-reported outcome measures, and we wanted to see how they were doing long-term because there was no placebo rescue. So patients taking placebo had been randomized either to active anifrolumab 300 or placebo continued, and the patients taking anifrolumab were continued if they were on the 300 milligram dose in this long-term extension. So we looked at the SF-36 as a standard measure of health-related quality of life and well-validated in lupus, but we also looked at 2 health utility measures, the EQ5D and the SF6D, trying to understand whether they varied according to glucocorticoid use, and also to look at the long-term impact of anifrolumab treatment. So under the method, you can see the study design where TULIP 1 took the 300 milligram and the placebo patients, and TULIP 2 took all the anifrolumab treated because they all received 300 and the placebo, and they were enrolled in the long-term extension. And as I said, it was as long as 3 years, but some patients were treated for 4. And it was a long a large population, and the inclusion and exclusion criteria were exactly what they were for the phase 3. But what we looked at is also patient global assessment of disease activity, the health-related quality of life, the SF6D, which is a utility measure which is based on all 8 domains, therefore all 36 questions of the SF36, and the EQ5D, which is a health utility measure based on the VAS, the EQ5D, 5L, 5 VAS questions. And then there was also the WPAI as changed somewhat for lupus, and a statistical analysis was exploratory, but we were basically trying to understand whether we could see long-term benefit of active therapy. And one of the points of this population was that a majority of them were working, which I found very interesting for a lupus population. So if we look at the results, I'm going to show you the traditional spidergram of the SF36. So we're looking at that figure at the top. And at the very, very top is a physical functioning domain. And then if we go clockwise, there's role physical, bodily pain, and general health. Those are the 4 physical domains of the SF36. At the bottom is vitality or fatigue, then social function, role emotional, and mental health. They're considered to be the mental health domains. When we look at a PCS, a physical component summary score, or a mental component summary score, MCS, we're not seeing the same thing. What we're seeing is a PCS weights the 4 physical domains and vitality positively, the remaining 3 negatively. The MCS weights the 4 mental domains positively and the remaining 4 negatively. So they're neither symmetrical nor are they consistent. And it's difficult to really understand what a PCS or an MCS score means. And so we've been looking for a single measure that would reflect health-related quality of life based on the SF36. And we thought it would be important to look at this health utility score. But first, let me take you through the SF36 results. So you see first the grid lines, and then the inner polygon in green are the baseline scores. So they're quite low, as we might expect in a lupus population. The outer yellow are the normative age and gender match scores for the United States, but actually they're very similar across Northern Europe, Western Europe, and multiple countries, so they're not that different. As we build this out, the blue is then the long-term extension on placebo. And then you'll see, just as it extends a little bit further, the anifrolumab group does show more improvement, particularly in the bodily pain, mental health, and general health domains. So do we see that with the SF6D or the traditional EQ5D utility measure? And the answer is yes, if we look below. So I'm showing you first the SF6D on the left, and in the red is the anifrolumab long-term extension patients, and the blue is the placebo patients. And you can see that there is improvement by the SF6D, and it does, in general, the mean meet or exceed what we call the minimum important difference. That means it's clinically differentiated, means it's clinically important. If we look over on the right, we're looking at the EQ5D, again, based on the 5 VAS questions. So not as many questions and not questions as specifically relevant to lupus as the SF36 can be. And you can see similar results, although the EQ5D doesn't generally meet the mean of the MID, where we would expect that greater than or equal to 50% of patients would have clinically meaningful improvement. So overall, what this idea is that we could use the SF6D as a single measure of health-related quality of life. And that might be a way to put this complicated patient-reported outcome concept into a composite measure as a single measure of patient-reported outcome. Interesting idea. This is just an experiment that we've started.
Very interesting, Vibeke. Fascinating work and so timely right now as we're trying to redevelop outcome measures in lupus, right? And think about how we can have the patient voice, the patient perspective, which has been lacking for many, many years, in my opinion, right? And we all know that in our experience taking care of our patients living with lupus in the clinic, and also in the clinical trial setting, that their experiencing of their disease, of their active disease, of how their disease affects their daily lives, how their medications affect their quality of life. Many of these factors aren't measured accurately with how we're currently assessing our patients. So I applaud these efforts. And I know that you're leading the field in this area, and I think it's very important. It's exciting to think about now these health utility indices that could potentially, as you said, be placed into a composite outcome measure.
Yeah, I would hope so. I think particularly if we could look at the SF60 because it contains so much more information ultimately. It's just an interesting idea because asking a patient global, we know that there's so much discrepancy between patient and physician assessments, but not just that discrepancy, but the discrepancies among the various PROs that patients report. Whereas when they go through a health-related quality of life assessment, such as the SF36, there seems to be much more consistency as they become familiar with the questions and they think through them on a regular basis.
Interesting. That's very helpful to know. Thanks, Vibeke.
Thank
Well, I
you.
think I think that's all that we have time for today. Thank you again, Vibeke, for sharing your insights and joining me today to discuss these fantastic papers. And I want to thank all of you for listening to us today. You will find the slide decks for these papers and more at lupusforum.com. The Lupus Forum is free to access. All of the content is free to download, and you can use the slides and content for other talks that you might be giving in your areas. If you're not already, make sure to register for updates on the Lupus Forum. You'll receive email updates when new content is made available. And you can also follow us at Lupus Forum, all one word, on Twitter, X, and LinkedIn. Thank you again, and see you all next time.